Okay, let's start with some basics with fluids. So everything maintenance-wise is going to be pretty much on this slide that you're going to use in clinical practice. Most commonly, normal saline is going to be by far and away your maintenance fluid of choice. The reason is people can tolerate a fair amount of normal saline without really anything adverse happening to them at all. If you give people a lot of dextrose over time, it can increase their blood sugar. It can be problematic for diabetic patients. Normal saline is isotonic and won't fluctuate sodium levels to an appreciable extent, at least not a clinically significant one. We'll talk about that maybe with patients who have really low sodiums. We can use it maybe to increase it a little bit, but for the most part, normal saline is a good choice. I have heard occasional patient complaints that people can taste like a salty taste when they're getting saline infusions, which I don't know if I totally buy that. It's not higher concentration in salt than what you have in your normal body for most people, so I don't know if that's just psychogenic or not, but we'll see. You might hear that come up, but otherwise, again, that's going to be your primary workhorse as far as fluid boluses and fluid resuscitation. Dextrose is a nice alternative. It's really used for resuscitation or bolusing people, replacement fluids. We use it a lot for delivering different IV drips, though. A lot of things are compatible in it. Not everything is as compatible in normal saline, so it tends to be our drip drug of choice. So if we're doing a continuous infusion, if we're doing like an IV antibiotic over 30 minutes or an hour, usually it's in dextrose. But a lot of those things are compatible in normal saline too, so you might see both. So don't get too concerned if you see it. Really, both are okay. Why, honestly, we do it one way or the other, I'm not exactly sure. I think that the dextrose, not doing it as a continuous infusion or large fluid boluses makes sense, not to increase the amount of sugar you're infusing into somebody. Why we don't use normal saline more for our maintenance bags, I don't know. At this point in our current situation, we're taking whatever we can get, basically, from whatever distributors we can get. So, again, you'll see different institutions practice differently, but pretty much what you can rely on is that normal saline is going to be your maintenance fluid of choice. There's various combinations too. You might see E5NS, which is normal saline and dextrose 5%, so it's not isotonic. There's going to be more solute in there. Or you can get a similar isotonicity kind of with E5 half normal saline. That's another common maintenance fluid. So you can see these used for a variety of reasons. If somebody's hypernatremic, you might want to decrease the sodium concentration a little bit. You still want fluid replacement. You aren't going to infuse sterile water into somebody, so that's going to really mess things up. But it's going to be really painful too. But there's some other things you can try. So it's not as common, but you might see it done here and there. Lactated ringers, I've got a chart on the next slide that tells you what's in that. That's something that's commonly used in OB. And I've seen it getting a little bit more popular just recently in ICU and emergency care for like sepsis and things like that, where people need an initial fluid bolus. They've been going to lactated ringers. I don't know if there's been some recent data to push that or not, or what the change in that is, but I have seen that trend taking place. But for the most part, it's really limited to OB, which why I'm not exactly sure. It's probably just a long-standing practice that they've used for quite a while. We had a bunch of our OB stuff in lactated ringers, and then lactated ringers went on a shortage situation, so we had to switch everything to NS, and no one seems to really care. So there's that. Again, I don't really know if it matters a whole lot, or if it's just more historical context and why we still use it. And then there's colloids and versus crystalloids. So these ones we've all talked about would be considered crystalloid solutions. Colloids would be anything that's a larger molecule. So albumin, head of starch, blood, and plasma products would be considered colloidal too. Colloidal products are going to be more with a specific purpose in mind, not just for fluid resuscitation, but like if somebody's malnourished, you want to get their albumin levels back up or avoid extra third spacing effects. Head of starch is a similar concept there. Blood and plasma, of course, could be replaced due to trauma or whatever reason you're replacing your plasma due to low iron or high INR. Potentially, you can reverse it with plasma too. Colloids are going to be more process involved. So if you get a blood bank, type and screen the patient, all types of that stuff. For blood products, albumin is generally kind of expensive, but useful in a lot of situations. So usually for basic fluids, you're always going to stick to crystalloids, and then colloids are going to be something you're going to use situationally. And I just put this up here. I'm not going to test any of this, but in case you want to look at where's our lactated? Here's LR. So what all's in LR? You can see like the pH differences between different products. See sodium. It's a little bit lower than normal saline, but there's some potassium and some calcium in there too. And then, of course, some lactate. So, yes.
Do you know why it's so acidic? Why don't they make it like blood?
I don't know why it's so acidic. It's a good question. I'm not sure why sodium or normal saline would be that acidic. And I don't know exactly why it would be not the same as like a standard solution, or it could be the manufacturer too, which is what you're seeing with ranges here. As far as D5, yeah, I don't know exactly why that would be more acidic. Could just be they can't buffer it that high if they're using whatever water source they're using. I'm not sure. You think the water would be pretty close to neutral. So, I don't know. Good question. Don't have a great answer for you, unfortunately. All right, so we're going to talk about some different fluid abnormalities and how we treat them. Some of the stuff borders on emergency medicine, critical care, so we'll try and walk a fine line between not getting too much detail on that, but still giving all the primary treatments and those types of things that you should know. So sodium disorders are primarily a relation of hydration status and how hydrated the patient is. So signs and symptoms are going to be due to cell volume changes. And so if your sodium gets really out of whack, fluid shifts. And the further out of whack it gets, the more fluid you have shifting. So if you have a lot of fluid shifting into the cells, that can be problematic, and shifting out can also be significantly problematic too. Rapid shifts are the big problem. So that's where we get most concerned when we see really high fluctuations in sodium, whether it's up or down. It can be devastating in some cases and have neurologic toxicity involved with it. So we really want to watch it. It's not the most common thing you'll ever see, but it's something worth talking about. So hyponatremia generally would be sodium under 135. Now, it depends on what your lab is. Different labs will calibrate their equipment differently. So where one hospital might say they might define a hyponatremic or flag this for 135, another lab might say 136, 134. I don't know. The different ones will have different equipment that do differently. So there's not like a national standard per se, so you might see slight fluctuations in that. For hyponatremic patients, we're most concerned for elderly and neonatal patients, but you can have symptoms with anybody. And really, it's going to depend on a couple things. So how low, how acute, and presentation, and what's the patient doing, and what are their symptoms. People present very differently with different stages of hyponatremia. And mild hyponatremia and chronically mild hyponatremia usually is pretty asymptomatic for most patients. It's those really acute drops of really, really low sodium that you're going to see the big changes in people. So mild symptoms for some mild hyponatremia. People might be a little lethargic, they get some muscle cramps, anorexia, GI symptoms, and headache. Pretty nondescript stuff. Nothing you would, immediately think, oh yeah, that's hyponatremia. But maybe if they had all of those and their sodium was like 120 or 125 or 130. And then severe symptoms. This is where it gets a little interesting. So you get altered mental status and confusion, agitation, disorientation. You almost have a psychiatric disturbance-like picture. So I've seen a couple of severe hyponatremic cases in our ED, and the patients present a lot like a mental health exacerbation, like an acute schizophrenic episode or acute bipolar or something like that. It's not good for the patient, but it's interesting to see how different it can be from like a patient who's maybe just chronically hyponatremic to somebody who's acutely hyponatremic and having symptoms that are active. So how does this happen? In the hospital setting, if you give somebody a D5 infusion for a really long time without adding saline, you're going to dilute out their volume, and therefore their plasma sodium is going to drop. So that's a cause. That's another reason why we don't like to give D5 aggressively over a long period of time. Pretty easy fix if this happens. We switch to normal saline, switch to D5 half normal or D5 NS. Something with saline in it should be replaced. And this would be a rare situation. So we don't use D5 for that purpose, or should be, but it is a possibility. Hyperglycemic patients can have an increase in serum osmolality, and so water is pulled from intracellular to extracellular. Other things can do this too. Mannitol infusions, I talked about during the kidney lecture, do a similar thing. Radiocontrast dye can do that as well. And most of those cases, like a mannitol infusion or radiocontrast dye, wouldn't be chronic enough to really cause a big difference, I think. But if you're hyperglycemic or really hyperglycemic for an extended period of time, that's where you can see sodium decrease. So I put these little tidbits down here. I'm not going to test you on corrected serum sodium or anything, but just know that a hyperglycemic patient can incorrectly display sodium. So you want to do a corrected calculation. So you do the observed blood glucose minus 100 times the normal blood glucose, whatever you define that as. So 100 would be the general one, but if you wanted to define that differently, you could. Divided by 100 times 1.7, that's your expected decrease. And so you look at the observed or the lab measured one, plus that decrease, and that should give you your corrected sodium. So just a different way to calculate it there. So the point is, if somebody's really hyperglycemic and you're looking at your labs, just remember that the sodium is probably not correct. You might have to correct it that way. Some labs might report it corrected specifically, but not all of them will do that. All right, some more serious causes that you're going to see people in critical situations or really acute changes. Diarrhea, dehydration, and diuretics can all cause this, and probably the most common causes you're going to see in otherwise generally healthy or reasonably healthy patients. So a person who's had really profound diarrhea or maybe had norovirus or something over the weekend, and they come in and they're really dehydrated, they're hypovolemic, they've just been wasting sodium. Now, this can depend. Sometimes dehydration can actually concentrate sodium. It depends on what other intake you have going on. The dehydration can do both, potentially. That's why I see it listed on hyper as well. Diarrhea combined with dehydration, that's where your body's just not really absorbing any more electrolytes and you're wasting them, you're not getting any intake. Diuretics should make sense. Loop diuretics specifically would be the big target there. Thiazide diuretics. Loop diuretics can waste sodium too, but we don't see it to the extent that we see with the thiazide. So the couple cases I've actually seen that have been clinically significant were both due to chlorthalidone. People do starts on chlorthalidone and or increases in dose of chlorthalidone that actually cause them to go into like the 1/10s, 1/10s in their sodium. Different things that affect the way the body clears fluid can affect sodium, of course. So CHF increases in fluid retention can dilute your sodium out, causing a hyponatremic picture. Different kidney failure issues, hepatic cirrhosis can affect the way that the kidneys get rid of sodium or increase their clearance of sodium. Renal failure, we'll talk about SIADH a little bit, polydipsia. These can all be isovolemic, where you don't really have volume status changes, but your body is still wasting sodium in an aggressive way. And consider your rate of decline and severity of current disease state. So that's really the biggest thing here is what's the disease going on, how exacerbated are they on whatever disease you're looking at, and then how fast have they declined. And usually you're going to see symptoms with a severe decline. Somebody's going to be confused and you're like, why is this 42-year-old woman who has no history other than hypertension confused? Well, she's on chlorthalidone. What does that mean? Or there are some other medications that do this too. Some can induce SIADH. Talk about this a little bit during mental health, but there's some antidepressants that can do that rarely too. It's not as common as the diuretics, but it is possible. Okay, so how do we replace this? Well, if it's not critical, meaning not symptomatic, usually I would consider not symptomatic, not critical. Even if somebody's sodium is pretty low, they aren't showing symptoms, I wouldn't aggressively replace them. The reason is because aggressive replacement can be is considered a pretty high-risk process. If you do it too aggressively, you could cause osmotic demyelination and permanent neurologic damage. And we could do this in a controlled environment, but it is something just to keep in the back of your mind that this is a really high-risk medication. So, not critical. Fluid restrict. Try oral sodium. If they're hypovolemic, you can just replace their fluids with normal saline. Normal saline is 154 milliequivalents per liter. So if we're talking about sodium hyponatremia, the sodium level being below 135-ish, if you gave them normal saline over a long enough period of time, it should start to creep up slowly, right? Because you're getting more concentrated product. Hypertonic saline is the other choice we have, which is 3%, and that's 513 milliequivalents per liter. So this is where we give it to our symptomatic people who are critically ill. And we want to avoid any more damage than what we're seeing. So we're seeing psychiatric symptoms, likely a sign of something going on, some sort of brain fluid shifts that we want to correct as soon as we can. But we don't want to do it too fast, so that's the double-edged sword here. Do it too fast, you cause more damage. That's a bigger problem than you started with. So there's some guidelines we want to watch. This serum sodium and do about 12 milliequivalents per liter over 24 hours. This can be hard to really titrate in. My best advice to people is when you're going to do hypertonic saline, go slow. There's a lot of recommendations on how to dose people out there, but generally I've never seen people do something really aggressive, like a big bolus of saline and then try and catch up later. We do something like that for critical brain bleeding, but that's a totally different situation than what we're talking about here. So start low, go slow. You can always increase your rate of sodium and increase how fast you're getting it. But usually these guidelines are a pretty good recommendation. I'm not going to test you on the numbers or anything like that. What I want you to know is just the difference between critical and non-critical. So non-critical, fluid restriction, orals, maybe normal saline. And critical, usually you get somebody hypertonic in almost every situation. This is a website I'll go to quick here. Have I talked about global RPH before? Probably not. I don't use it very often, but it does have some interesting calculators on it. When you go to globalrph.com, it looks like you can get to a really sketchy website because all the graphics look like they're from a different generation. I think that despite the fact that there's a lot of weird advertising and that it doesn't look all that good, it actually does have some nice stuff. I can go to the beginning of it and show you in a second. But if you Google like saline calculator global RPH, you should be able to pull this stuff. But this is just an example of how you can replace somebody. So that actually uses some practice, believe it or not. One of my friends told me about this. Where are my fields I can fill things in? Let me try something else here. Something's wrong. Let's try just connect global RPH. Sodium. Wow. Alright, there you go. Oh, see, like this, that old link, like they upgraded their graphics and everything. But you still get lots of ads, which makes you think, like, man, a real website is like about MD or something. Alright, so let's say we have a 70 kilogram male, we'll just leave it that way. 100 would be a really low sodium to come in with, so let's say 10. Still pretty low, but maybe more realistic. Our target sodium, remember, we only want to go up about 12 in a 24-hour period. So this puts it at 15. That's probably fine. I mean, this isn't an exact science. If you really want to be closer, you can say, okay, let's start at 122 and keep our max right here. You can do a drop down if you want it to be more aggressive, but yeah, I don't recommend doing that. You got any injury back there? Alright, so if you submit that, you get a rate of 40.9 mils per hour, and that's pretty standard. So usually, you can play with this calculator if you want, but no matter what, if you're looking at this 0.5 milliequivalents per hour, you're usually going to see, or per liter per hour, you're usually going to see it land somewhere between 25 and 50. And that's a good, if you're thinking about how do I replace hypertonic saline, you want to take home point. I think usually in the beginning I would start maybe if they're really symptomatic at around 50 mils per hour, and then you could taper down to 25. You're going to be checking their sodium every hour, so it's not like it's going to run away on you, and you can easily turn it off if you overcorrect a little bit too much. And if you keep it low, you aren't going to overdo it in a way that's critically ill for the patient. But you can go online and find different ways to do boluses and all kinds of crazy things like that. There's really complicated calculations, but at the end of the day, this is a nice, easy way to do it. So if you work in emergency medicine or any like type of critical care situation, this is a good one to keep in the back of your pocket. And Global RPH actually does have some decent calculators on it too. So if you browse the site, you might find stuff that's interesting. Maybe not, but there are some good references, and it is pretty legitimate. All right. Any questions on deficit calculations or hypertonic saline? Talk about SI-ADH quick. So syndrome of inappropriate antidiuretic hormone secretion. So you've got too much antidiuretic hormone secretion going on. This can be drug-induced. There's a drug called desmopressin, which we'll talk about in a second here, that can induce it. Some antipsychotics, antiemetics, and antihistamines can induce SI-ADH. SSRIs, which are selective serotonin reuptake inhibitors, the most common antidepressants on the market, can do that. So drugs like Prozac and Lexapro. Carbamazepine is an older anti-epileptic drug, but it's still used quite a bit for things like neuropathic pain and some other indications. Cyclophosphamide, vincristine, chemotherapy drugs. So there's a pretty wide variety of drugs, and actually some, especially within mental health, some pretty common ones. If you work in mental health, it might be something you run into where you see people who just have sort of a depressed sodium, chronically low sodium, and that can be due to drugs. So you can try taking the drugs, or you can try treating it differently by fluid restricting. You can increase sodium intake, which is usually not all that hard to do. If this is severe, they're having a severe episode of SIADH, maybe you just doubled their dose of carbamazepine and they went from, having okay sodium and now it's like gone down by 20 in a week, something crazy like that. That would be a time to do hypertonic. So this this is still, in its essence, hyponatremia really, is how we're treating SIADH. But there's a couple different things we add. Loop diuretics can help to get rid of some free water, which can help concentrate your sodium a little bit more. Remember, loop diuretics waste a little bit of sodium, but not a ton. Vasopressin receptor antagonists are a different drug we can try for this too. So these drugs end in the word baptin. And I'm not going to spend a ton of time on them, even though they're really the primary drug per se. When these drugs have been compared in clinical trials to fluid restriction and saline replacement, they haven't really fared all that more beneficially. And they're really, really expensive. So they do have a role, but it's a little bit nebulous at this time. So mechanism and dosing, what they do is they promote free water loss without sodium loss via decreasing collecting duct permeability to free water. So you're working in the kidneys in a place that's not excreting sodium, so you're resorbing your sodium but still getting rid of free water. So it's not all that different from the way a loop diuretic would work, except loop diuretic's still going to waste some sodium, and even though its water removal process is going to overcome that, this is a more perfect version of that, if you want to think about it that way. So it's kind of like a diuretic, a sodium-sparing diuretic, if you want to think of it from a simple term. You IV load them, and then you do a 24-hour infusion. It's a max duration of 4 days. It can be hard on the kidneys over time, and you can overcorrect things, especially if you've got a critical situation. Sometimes they will combine a drug like this with a hypertonic saline infusion, and then you can be in really hot water if you aren't monitoring very carefully. So this drug, again, expensive. We don't like to use it that much, but does have some utility. Basically, if you had an acute situation, the patient wasn't responding to a saline infusion very well or not well enough, this would be a drug worth adding on. But for the most part, the evidence isn't clear in favor of this. It's actually pretty wishy-washy, so it's not the best option out there. It is a tool we can use to correct low sodium. Yes? Do you just use that for SIADH? You could technically use it. It's approved for SIADH, but you could technically use it for any hyponatremia case. Yeah. All right, hypernatremia, so high sodium would be quite a bit different. So again, you could have this as a dehydration cause potentially. Increased sodium intake would be pretty hard to do unless your kidneys are failing. If you eat a ton of salt, the odds are you're just going to pee out a ton of salt. But if your kidneys are failing or you have heart failure or something like that, that's where you can start to see enough retention where your sodium shoots up quite a bit. Mineralocorticoid use, so like fludrocortisone use, could cause this, and diabetes insipidus as a disease in general can cause people to be hypernatremic. It's much, much less common than hypo. It's very rare to see somebody hypernatremic, and even more rare to see somebody symptomatically hypernatremic. Usually you have to be above 160 to be associated with any type of high mortality. It is serious if it happens, it's just unusual. So if you treat the person, you're going to look at their volume status. So if their volume down, you want to rehydrate them and restore intravascular volume. So this would be a good chance to use maybe some dextrose or something that's not sodium related to help dilute out that sodium a little bit. If they're IV fluid overloaded, you want to use a loop diuretic. That should get some of the, or if fluid overloaded, you want to use your loop diuretic. That should get some of the fluid off. It can help waste some of the sodium over time as well. And diabetes insipidus, if you have that specific disease state, you're going to decrease free water, and consider the drug desmopressin. So desmopressin, or DDAVP is the brand name of it, you might hear it called that, is basically synthetic antidiuretic hormone. So this is really the opposite of what somebody with SIADH would have. So think of them as functionally opposite, diabetes insipidus and SIADH. You can give it orally or nasally, and it's a drug that just basically gives you antidiuretic hormone when your body's not making enough. And that's really all there is to that. Again, don't want to spend a lot of time on it. It's really, really unusual to see it. All right, moving on to potassium. Potassium is by far the most critical electrolyte disturbance you can have, especially with hyperglycemia. That's the one that is going to be probably the most common in a significant way. So serum potassium levels are giving us insight into intracellular issues, and you're responsible for protein and glycogen synthesis, resting membrane potential. So particularly within the cardiac membrane and cardiac myocytes, this is where we can get into big trouble with potassium changes. So conduction and arrhythmias are the things we're going to look at with either hypo or hypernatremia, or kalemia. Getting my emias mixed up. Okay, so hypokalemia. So low sodium, usually asymptomatic until your potassium gets quite low. It's much better to have low sodium than high sodium in conjunction, or in contrast to our discussion on why I keep saying the wrong electrolyte, don't I? Sorry, potassium. Let me get on the right page here in my brain. All right, so anyway, much better to have low potassium than high potassium, and it really takes a lot of potassium deficiency to get some symptoms going. You can see some muscle weakness. It can possibly induce rhabdomyolysis at really low levels, and you can get EKG abnormalities too. But it takes a long time to get somebody down to that low of a potassium level. And potassium is really easy to replace orally or IV. It's not a rocket science type situation. So some people, you might see this in hospitalized patients, malnourished patients, alcoholics, people on like massive loop diuretic therapy that aren't getting monitored correctly. But most of these patients in these situations, maybe with the exception of alcoholics, like if they're hospitalized or they're on loop diuretic therapy, they should be being monitored for electrolyte replacement. That's just common sense, and that's standard of care. So if that's not happening, there's a bigger question at hand. But technically, that would be probably the way you're going to see this happen. And certainly, you can end up accidentally or maybe even intentionally overdoing loop diuretic therapy, and then you don't realize it until it's too late. Your potassium comes down. The other thing to think about too is that people who have low potassium also usually have low MAG. MAG is a cofactor in potassium uptake. So if your MAG is low, and you can end up in a situation where you keep trying to replace somebody's potassium, especially if you're doing it orally, and nothing happens. And you have to replace the magnesium too. The two work together. And if you aren't getting the results, just make sure you check a MAG level to see if the magnesium is low as well. All right, so replacement. Potassium chloride is our primary product, either TO or IV. The tablets come as a number of different forms. There's Chlorcon and Cater and a couple other brands. Those are the common ones. They're tablets, packets, and liquid. I always get this question from providers and nurses. My patient hates taking these gigantic horse pills. Is there something else? Yes. So there are something else. But these pills are really big. If you've seen a potassium pill, they're like, they're pretty significant in size. So I do get it that people don't like taking them. They're large. So there are packets of powder you can use. So you can sprinkle that in somebody's food, applesauce, whatever. Some of the tablets actually, you can't crush them because they're usually extended release, but you can sort of dissolve them into a slurry of water, which allows patients to take it as like a solution instead. Just be really careful not to crush the thing. If you crush it, then you're going to get a big release of potassium and the person takes it all at once. It can spike their level. That can be a problem. So try and if your nurse ever asks you, how do I take this, or how do I get this, can I crush this? No, you can't. You shouldn't be asking pharmacy that, but in case you get that question, or you get it from a patient in your clinic or wherever you end up practicing, just know that you can dissolve some of them in the liquid. It does come as a liquid form too, so you can hear just a straight solution. I'm sure it tastes terrible, but it's there. And it comes IV, so that's what we give for our hospitalized severe patient. You can replace potassium IV pretty aggressively, especially if you have the central access. If you don't have a central access, you end up with a lot of phlebitis in patients. So you can only give it so fast. Usually it's like 10 milliequivalents per hour, which if you have somebody who's got quite a big deficit, they can end up needing 80 to 120 milliequivalents. So that's like 8 to 12 hours of replacement tying up an IV line if you don't have central access. So it can be problematic. It's also a lot of fluid too. That's probably 1.5 liters or so of fluid up to. So if your patient's fluid overloaded, that could be a no-go. So central access can help with that. You can get it faster. We get it 20 milliequivalents per hour, and it's more concentrated. And oral. If the GI tract's working well, potassium is really bioavailable. So if you give somebody tablets, it should work almost as well as IV. It's just going to be a little bit slower onset. Oh, my dietary comment. Yeah, you can't just eat a bunch of bananas. This was explained to me, and I actually never looked this up, so I probably shouldn't repeat it. But I had a really smart physiology professor in pharmacy school, and I believed him, so you guys can challenge me if you want. But he said that the potassium salt that's found in foods, so bananas are kind of stereotypical as having a lot of potassium, but I think a lot of things actually have a lot of potassium in them. But anyway, let's say you ate a ton of bananas. Well, apparently your body can only absorb the certain potassium salt that's found in bananas versus potassium chloride, which is a more bioavailable form. Yeah, I don't know if that's true or not, but he told it to me and I believe him. So, so I'm passing on his wisdom to you guys as a medium. So don't shoot the messenger. Normal requirements. Most people are going to require about 40 to 80 milliequivalents per day, and most people get that dietary. That's not usually an issue for the majority of people. Of course, if you have, if you're on parenteral nutrition or if you're malnourished, you're going to be out of whack. So if you see like the alcoholic patient come into urgent care or the ED, sometimes they might give them some potassium supplementation right after that. Hospital protocols are really common for potassium replacement. I talked about this a little bit with loop diuretics, but just to reiterate it, it's something that usually as a provider, you just type in, I want potassium replacement. That includes monitoring, that includes the nurse checking levels and contacting the lab, that includes the nurse entering the orders for you, and that includes a pharmacy double check on it. So it's pretty much a nice little package deal. All you have to do is look at the labs and make sure everything looks good on your end, but you don't have to physically manually order your labs and order everything because other healthcare professionals are doing that for you. So it's a nice way that you can give that task to the people who are kind of frontline. Not that you wouldn't be frontline, but with the patient all the time, they can handle those types of things. Yes.
Can you explain again why you can't crush them, but you can dissolve them?
Yeah, so they're extended release designs. So because potassium chloride is very bioavailable, if you gave it all as like if you gave a ton of powder, for example, it could all potentially absorb really quickly. The capsules and tablets are designed to release slowly so that you get more steady state release of potassium, and if you crush the thing, it can absorb really quickly. So then you end up getting a spike of potassium right away, which could be dangerous, but the bigger problem is that you're going to not get that sustained level, and then you're going to need more replacements sooner after that. So you could be kind of getting inappropriate labs when you're looking at it. So let's say you gave a dose, right now, and then you're supposed to check it 8 hours later, but if you crushed the dose and gave it, you could have gotten a peak in an elimination much quicker than if you gave the extended release formulation. So they're like these weird matrix things, and they kind of turn into a slurry when you mix them with water.
So if you do a packet, do you have to take it more often than throughout the day?
Yeah, usually in the packets, the packets usually come in lower doses too. So yeah, I'm not sure if the packets have some sort of an excipient ingredient in them that makes them release slower. But yeah, the packets can be a little bit challenging. So if you do go with a packet, it's something to remember. But for a lot of patients, they can tolerate it okay. It's the big doses of oral you might want to stick with the extended release. Yes.
So are you saying you can take one of the pills and dissolve it in water and drink it and you wouldn't get that effect?
Correct. Yes. So it turns into a little bit of a slurry. If you crushed it in water, like with mechanical force, that's where you break open this little matrix. It's kind of like a polymer matrix that it's in. It's compacted into a capsule or a tablet, and then it disperses with water. But the little tiny individual packets that release stay together. Kind of fancy drug delivery there. Okay. Follow-up is essential for monitoring, otherwise you don't know what you're doing and you're going to go over their potassium goal and then you're in a whole world of new problems, which would be hyperglycemia. So hyperglycemia, serum K greater than 5, it's more dangerous than hypoglycemia, and it's this one's something we see actually quite often resulting in a medical emergency. I had probably an uncountable number of cardiac arrests due to hyperglycemia. The most common presentation is a dialysis patient that missed dialysis. So kidney failure patients, end-stage renal patients require dialysis to remove potassium. If they don't do that, they're going to be in this situation and they're going to be at high risk for cardiac arrest. So that's what kills dialysis patients who miss dialysis. And I've seen it happen. Again, I can't even count the number of times it's happened. It's sad, but it's the biggest thing that we see. So if you're going to emergency medicine or kidney management or anything like that, it's worth noting. I think it's just worth noting for everybody. So we'll talk about this in a little bit of detail. I'll also come back to this during emergency medicine in a little more detail to round that lecture out, but we'll talk about the changes today. So what you're going to see with hyperglycemia, is a couple things. So symptomatically, we're most worried about cardiovascular issues. And what we're going to see is EKG changes. So hallmarks of high potassium, wide QRS, peak P waves, small absent P waves. You can have all three of those or one of them, it doesn't matter. And the more severe you get with potassium, usually the more you go from this wide QRS complex to more like a ventricular fibrillation or ventricular tachycardia. And that's where you go into arrest at that point. Treatment's based around driving potassium into the cells. So you could technically get somebody to dialysis and try and remove potassium, but that's not fast enough in these situations. So we need to see if we can get that potassium out of systemic circulation back into the cells. That's really what's happening, some kind of a shift as the potassium gets out. If we can shove it back into the cells, we can decrease its effects and availability for the cardiac cells to be causing problems and decreasing the way that we're making action potentials. So we start based on our EKG. So that's the first step. We want to get an EKG in the patient. If there's no acute changes, we want to focus on getting their potassium down, but we just don't have to do it as aggressively. If the acute changes are present, we're going to start with progressive therapy, which includes cardiac stabilization, or cardiac membrane stabilization is what we call it. So this is the treatment algorithm. The first step is only if you have EKG changes, you're going to give calcium. You give IV calcium in a bolus form, and that's just because it has an effect that stabilizes cardiac membranes in the situation of hyperglycemia. Now, is it going to work great? No, but it's a quick fix that might help prevent them from going from like a wide complex QRS, they're still with you, to a ventricular fibrillation a few minutes later. Step 2. This step 2 has a number of things in it, but insulin is the primary one. So I get this question every year, like, well, is there an order to these? And kind of, but everything revolves around insulin, and that's your primary drug here. So insulin actually, in addition to taking care of blood glucose, it does drive potassium back into the cells. It works by stimulating a sodium-potassium ATPase, so you're exchanging sodium for potassium, and it does that aggressively. So if you give that big bolus of IV insulin, most people take it sub-Q, but in this case we're giving them a fairly decent dose IV all at once as a bolus. It can help push insulin, or push the potassium back into the cells pretty quickly. You can repeat this too if you need to, or you can start a drip of insulin and continue to infusion if you wanted to as well. The first step is insulin. So if you're going to give somebody insulin, you don't want to bottom out their blood sugar, because that's adding another problem that you don't need. So if their blood sugar is normal, you want to give them some dextrose. High blood sugar, it takes it to be really high before we really care about it. So if somebody's blood sugar is normal, or even low, definitely want to give them some IV dextrose to prevent the insulin from bottoming out their blood sugar. If their blood sugar is really high, then we don't really care. The other therapies, sodium bicarb, albuterol, and Lasix, are all kind of alternates or options. So usually, once your first 3 parts are done, so once you've considered if you need calcium or not, and you've done your dextrose and insulin, or just insulin alone, then sodium bicarbonate is another option that's usually given. It's not going to hurt the patient to try it. And it has a similar mechanism. It does stimulate sodium-potassium ATPase, kind of roundabout, but it's not quite as effective as insulin. Albuterol nebs can do the same thing too. They can stimulate the ATPase as well, mostly due to their beta activity. And then Lasix can waste potassium. Problem with Lasix is what it takes a while to get those full effects of it. So to diurese off that potassium is going to take a few hours at least. And that's a great option for somebody who is got slightly high potassium that has no symptoms, and you don't really need to do anything stat. Lasix would be a nice choice to try and get rid of some of that. But in this case, it's more of an afterthought. So at the end of the day, stabilize your patient, you've given all this stuff, you could say, all right, do we want some Lasix on board to eliminate some of that potassium? Or if they're a CKD patient, you get them to dialysis as soon as you can. The third step is sodium polystyrene, or Kxalate, or Tionex, so they're 2 different brand names, and it's an oral agent, so it's like a solution that exchanges sodium for potassium in the GI tract. So it pulls sodium into the GI, or potassium into the GI tract so that you can excrete it, but this takes a while. It takes like a day to work. So this is another option for somebody who's less severe. You want to get their potassium down, but you don't really need to do it soon. It could be a nice choice for like over a day period, but if you're acute, this is your last thing on your mind. I get that question from nurses a fair amount, because people put in an order set, providers put in an order set that has all this stuff on it, and the nurse says, all right, can I get the Kxalate? I'm like, well, have you done anything else now? I'm like, well, let's worry about the Kxalate maybe in a couple of hours when we care about that, but for now, let's focus on this stuff. So it really just depends on how critical the patient is. So I just wanted to give you all the options. Hyperglycemia is kind of a big deal, especially if you go into any type of acute care. You're going to see this, and you're going to want to be really familiar with this. But there are certainly non-acute options too, which would be more like the Lasix, either oral or IV, and then the Kexlate would be your non-severe options there.
So for the Kyle surgery one,
Yep.
do you give that in all acute cases, like after you've worried about everything else?
Yeah, a lot of time they consider it sort of it depends on the patient. If you send them to dialysis, that's probably good enough at that point. But over time, yeah, it'll help keep that potassium from rising back up if there's some other cause potentially. Or if the potassium you shifted a bunch into the cells and now it's starting to shift back out, that can be a problem too. So a lot of times they'll give that just as a prophylactic measure almost. But yes.
Can you always do Lasix even if the person doesn't have excess fluid on board?
Good
Can you
question.
run them a risk
Yeah,
of
you want to make
dehydration?
sure you weren't dehydrating them. So yeah, they're depends on their volume status. Yeah.
Okay, so you might not use that if you're thinking they're dry or
Right.
or you will.
Right. Yep. Yep. All right. Any other hyperglycemia questions? Calcium, I mentioned chloride versus gluconate, and since I'm not going to really talk about calcium directly during this, even though this is fluids and electrolytes, I'll talk about calcium. First lecture in the spring, we'll do bone mineral stuff, and I'll go into lots of detail about calcium as a supplement and how we use it therapeutically and all types of stuff. But for this lecture, just because we mentioned it here, if you're wondering about calcium chloride versus gluconate in the situation of hyperglycemia, chloride is just much more bioavailable. It's about 3 times the elemental calcium per gram. However, it's really hard on peripheral vasculature, so we reserve it for really acute. So this would be like the person who's crashing, who's going from wide complex QRS to defib right in front of you, and you need to get that calcium into them stat. That's where you're always going to use chloride. If the person's okay, but maybe you're seeing some PQ waves and slightly widening QRS, gluconate's probably the drug of choice, just because it's much easier on the vasculature and you can infuse it better. So the patient's going to like that better, but that's just the difference is, if you might need to repeat doses of gluconate, you're getting less calcium overall. At the end of the day, you're getting the same overall effect. It's just a slower onset, lower potency product. Think about it that way. Okay, so those are the big ones, sodium and potassium. We'll talk about a couple other ones. Right? Magnesium has a lot of different roles in the body. I'm not super concerned you know what they are. As far as low magnesium goes, this is something we do see in hospitalized patients. It kind of goes hand in hand with hyponatremia. You'll see this happen with patients on parenteral nutrition, patients who have a lot of diuretic on board. Their magnesium might kind of slowly waste along with the potassium as well. GI and renal disorders, people with inflammatory bowel disease like Crohn's or ulcerative colitis, common complication of that. Drug causes, diuretics, don't waste magnesium significantly. Some people would argue loop diuretics do, and you will see magnesium trend down over time. But magnesium is a little bit more robust than our other electrolytes. It's got a smaller range, and it's harder to get it out of range. And if you see a low magnesium, we don't really get too concerned about it. Symptoms can be CV and neuromuscular related, but it's rare to see like a critical CV event due to a hypomag. You have to be pretty low. Mostly mag, we're concerned about it because the potassium is usually low too, and again, we want to replace both of them because they're cofactors. And again, muscle cramps, maybe nausea, vomiting, lethargy, pretty much what we're going to see with all of our low electrolyte levels for mild cases, similar symptoms. Treatments, we want to get mag above 1.8 or whatever your lab says is good for mag. I think actually ours is 1.5, so it just depends on what standard they're using. Correct your potassium as well. Treat your underlying cause if you know what it is. A couple of different magnesium products on the market. There's some oral ones. There's magnesium oxide, which is the most common one you'll see used. And then there's some slow release ones. So the problem with magnesium is it does cause diarrhea, and it actually is used as a laxative for that reason too. But you'll see patients, maybe if they're taking the oxide, which is a more common formulation, it's cheap and it's easy to get. You can change them to like a slow release if they're not tolerating well enough. They might limit their diarrhea a little bit. But that's sort of the nature of magnesium therapy. You aren't really avoid that at all. It's going to be hopefully short term. You're going to have have somebody on chronic magnesium therapy, but every once in a while I see somebody on that. IV is mag sulfate, and mag sulfate we can get a lot of magnesium at a time, like 1 to 4 grams at a time, and it's usually given in a small volume, like 50 mils, or maybe 100 mils, depending on the concentration. And we can give magnesium IV push too if we really need to replace magnesium fast. We'll talk about magnesium sulfate a lot more when we talk about OB and preeclampsia. It's one of the primary drugs of choice for eclamptic seizures and preeclampsia, preventing seizures as well. But for this case, if you have somebody hospitalized, IV is a good option for magnesium. It's probably preferred to oral in a lot of cases because of the GI issues that the oral causes. If you end up causing a lot of diarrhea, getting a lot of the stools, not only is that problematic for the patient, but you're not going to be absorbing your magnesium as well, or any other thing you're trying to put in their GI tract. So oftentimes we prefer IV, even if the patient's relatively stable. If they have IV access, IV mag is probably the better way to go for a hospitalized patient. So hypermagnesemia is really uncommon. I don't think I've ever seen somebody with really high magnesium. Not that I keep track of this type of stuff, but you remember weird clinical cases throughout your career, and I don't think I've ever seen something like this. Not that it hasn't happened, I'm sure, but it's something that's unusual. Usually it's going to be kind of like high potassium, where you're going to see some sort of kidney injury associated with it, where the body's just not eliminating magnesium like it should be. And you can get severe CV or neuromuscular complications in rare cases, similar like you would with low magnesium. The way we treat it is checking the renal function, so we want to treat the underlying renal dysfunction. So think about last week's recorded lecture. Loop diuretics and fluids is really the choice therapy here. We're going to try and basically make the kidneys function by doing that. And then hopefully that'll correct the magnesium over time. When I put a bottle of this Walgreens mag citrate up here, so you can buy this stuff over the counter. They use this for colonoscopy prep sometimes. But if somebody has poor kidney function and they're taking this regularly as a laxative, that's where you could see potentially somebody in the community come in with a really high mag level because they were doing this inadvertently. Elemental calcium can be a physiologic antagonist to magnesium when it's in high levels, and so that can help offset some of the effects you're seeing cardiovascular and neuromuscularly. Supportive care, you can see possible symptomatic bradycardias with this, so pacing people out of that with electricity, using pressors, mechanical ventilation, help with respiratory issues in some cases. Again, very rare, very unusual, so it's really all I'm going to say. But there's not much to think about with this other than let's correct the kidney issues. That's going to be the majority of the cases you'd see with high mag would be kidney related. Oh, I didn't do the renal case. I did the renal case on this one. Sorry, you guys are probably thinking I'm crazy. I thought it was on the other lecture. Well, what do you guys want to do for the rest? Because that's the last slide I have. The rest of this, I just have the renal case. I don't know if